Good morning, all. And at the outset, I would like to thank the organizers. And I don't know, I can't see Dr. Deepa Gupta, but Dr. Deepa Gupta in particular, she's the one who said ki you have to come and you have to keep it to a very bare minimum to only the practical aspects of neonatal resuscitation. So I would not be dwelling with the papers and data. I'll just be talking about the practical points. And a major part has been covered by Dr. Bish, so that is going to help me out. So, introduction to the neonatal resuscitation program. Neonatal resuscitation helps to restore a baby from the state of asphyxia. Then the main aim of neonatal resuscitation program is to teach the steps necessary to ventilate a newborn baby that is not breathing and to protect the life of the baby. 90% of the newly born babies make the transition from intrauterine to the extrauterine life without any difficulty. They require little or no assistance to begin spontaneous and regular breathing. Approximately 10% of the newborns require some assistance to begin breathing at birth, and only 1% may need extensive resuscitative measures to survive. So we will be talking about these 99% of the babies. We can, I think, easily leave out 0.5 to 1% of the babies right now. Preparation. Just like you people must have prepared for this workshop, I think at least 2 or 3 months back, ma'am. So preparation of the birth is the key to success of the resuscitation, as we can manage resuscitation more efficiently and smoothly without any confusion and delay. And time is money over here. Questions that as soon as you enter a labor room, as soon as a pediatrician enters the labor room, the first thing that we see over here is the temperature. Just like Dr. Vandana told us about CAB. Over here the sequence is temperature, airway, breathing, circulation. Temperature being the most important and the initial one. We have to maintain the temperature of the labor room between 26 to 28. Then after, there are a few questions that we need to know before we proceed. Gestation of the baby, whether it is a term baby or a preterm baby. Amniotic fluid, whether it is clear or not. Meconium is not such a big factor now. We call it for amniotic fluid, whether it is clear or not. Perinatal risk factors, there's a whole list. And we discussed the umbilical cord management plan. As already Dr. Bish has pointed out, umbilical cord management plan is very necessary. If the baby, will be teaching that, if the baby is crying soon after birth, or is crying briefly after a brief stimulation, please delay the cord clamping from 1 minute to 3 minutes. This is the NRP algorithm. I'll be sending the colored copy to one of the organizers so that it can be circulated. So routine care. 2 minute baad mein kar? 2 minute baad mein. So what is routine care? All the babies that you saw in the 90% list, as soon as the baby is born, baby is put on the mother's abdomen, cord is not cut, baby is crying. We do drying and suction if necessary, and we keep the baby attached to the mother's abdomen along with the umbilical cord. After doing other small things like cleaning the eyes or nose, then after 60 seconds we can cut the cord, and this baby will remain with the mother throughout. This will help in early initiation of breastfeeding. If I'm sorry about the spelling mistake over here. In positive pressure ventilation, indications for positive pressure ventilations are apnea or gasping baby, heart rate less than 100, or if the heart rate is more than 100 but the baby is breathing but the target saturation is not being maintained despite free flow oxygen. If you remember the last slide that Dr. Bish showed, the initial saturation of a baby is 60 to 65. Even if the baby is not being able to maintain that saturation with free flow oxygen, that is an indication to start with positive pressure ventilation. So can you identify this instrument, please?
Ambu bag.
No, ma'am, this is not an ambu bag anymore.
Yes.
Ma'am, it is a self-inflating bag and mass assembly. So ambu is the name of a company now. So we are calling it a self-inflating bag and mass assembly. So we start ventilating by giving just enough pressure to observe a noticeable chest rise. The rate is 40 to 60 breaths per minute, and we give initial ventilation for 30 seconds. If there is no visible chest rise, means ventilation is not being done correctly, so we go in for ventilation corrective steps. There were a set of 6 steps earlier, they are reduced to 4. The first one is MR, in which we are going to readjust the mask, we are going to reposition the baby, again give 5 breaths. If still there is no increase in, there is no chest rise, then you go in for suction or open the airway. If still there is no chest rise, then we increase the pressure of the compression. Coming to chest compression, I hope कि इतना इसकी ज़रूरत नहीं पड़नी चाहिए. If we have done this, this is more than enough in 98 to 99% of the babies. So still, I was asked to comment on chest compression. It is done to increase the blood flow to coronary arteries, as improving coronary artery blood flow is crucial to restoring cardiac function. It is recommended when the heart rate remains less than 60 despite effective positive pressure ventilation. And of course, we have to increase the FiO to 100% and call for help. The rate of compression to ventilation is 3:1. 3:1 means we will give 3 compression and 1 breath. And there are 120 events. Earlier, when we were using only bag and mask, we were giving it for 30 seconds. But now when we are doing chest compression along with the bag and mask ventilation, we have to do it for 60 seconds before our next assessment. It contains 90 compressions and 30 ventilations in a ratio of 3:1. The key word over here is give coordinated chest compression along with positive pressure ventilation with 100% oxygen for full 60 seconds. Site, it is the lower third of the sternum, that is below the imaginary intermemory line. The depth is 1/3 the diameter of the compression depth. We have to use both our thumbs while encircling the chest. Compress the heart between sternum and the spine, and the rhythm is 1 and 2 and 3 and breathe. And this means compression, release, compression, release, compression, release, then breathe and then release. I'll just show you. So this is just summary that I'm going to do. I'm audible at the back?
Yes.
Good.
Not visible from here.
Not visible.
आगे आ जाइए सर थोड़ा.
So we have taken the delivery. The cord is not the baby is the कोई condition हो सकती है, baby cry कर रहा है तो भी आपको mother's abdomen पे रखना है, ठीक है. Baby cry नहीं कर रहा है तो भी आपको mother's abdomen पे रखना है. Please do a brief drying and stimulation. You have not cut the cord. See, so if the baby is crying, तो आप बाकी formalities कीजिए. Cut the cord after 60 seconds to 3 minutes, and baby will be in touch with the mother. Baby will be in contact with the mother's abdomen, and you can initiate breastfeeding. If the baby was not crying initially and you have placed the baby on mother's abdomen, most probably if you do a brief stimulation, the baby is going to cry. So again, आपने cord cut नहीं करी है. You have given the advantage to the baby, and you have placed the baby on the mother's abdomen. थर्ड कंडीशन क्या हो सकती है कि ये करने के बाद में भी बेबी ब्रीफ स्टिमुलेशन करने के बाद में भी बेबी इज नॉट क्राइंग. सो देन यू कट द कॉर्ड एंड टेक द बेबी टू द वार्मर. सो वार्मर पे आप ले गए हैं उसको. बेबी आपने यहाँ पे दोबारा ड्राई किया है, आपने दोबारा स्टिमुलेट किया है, जरूरत पड़ी है तो आपने सक्शन किया है और आपने रिपोजिशन किया है. यहाँ पे फिर आपकी 2 कंडीशंस होंगी. इज द बेबी क्राइंग ओवर हियर और बेबी इज नॉट क्राइंग. इफ द बेबी इज क्राइंग, so please take the baby again and put the baby on the mother's abdomen. वही सारी steps हमारी आ गई हैं. If the baby is not crying, even if on the radiant format, this is an indication to give positive pressure ventilation. And Dr. Bishop, can you demonstrate?
From chin, mouth and nose. You have to cover the chin, mouth and nose, and 2 fingers on the top, and with the other you can just do little bit of extension, and then breath 2 3, 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 breath 2 3.
Just देखिए जारी ऊपर. बढ़िया.
Breath 2 3, breath 2 3, breath 2 3, and you do it for at least 15 seconds to see whether chest is rising, heart rate is improving or not, and your helper is actually noting the heart rate. And if your help Effective ventilation will only be said if your बच्चा का heart rate बढ़ रहा है और chest rise हो रहा है. अगर chest rise हो रहा है, then you continue for 30 seconds. Then 2, 3. That means you will have to give at least 20 times. 20 to 25 times.
How much pressure in the
So how much pressure is very important, Dr. Adhikar? Pressure which just makes the chest rise, or visible chest rise, because every lung will be very different, every baby's gestation wise will be very different. You cannot use all three fingers on. I'm using only half of it right now. Breath 2, 3. Breath 2, 3.
हम सब लोग सांस ले रहे हैं ना, लेकिन हमें पता नहीं लगता है, because it is just a little chest rise which is needed for air exchange.
So I'm
Not more than that.
we are not doing like
We
this.
are not hyperventilating.
We are not doing like this. So it is similarly, if you see just a visible rise, and I'm so happy whenever I train obstetrician, they do better than the pediatricians because de-learning मुश्किल है, learning ज़्यादा आसान है. So all obstetric जो residents होते हैं वो बहुत अच्छी तरह से करती हैं, वो हमेशा ज़्यादा अच्छा कर देती हैं. In fact मुझे तो कई बार बेटर लगता है कि वही resuscitate करें तो ज़्यादा better है.
So even after effective giving positive pressure ventilation effectively, the heart rate continues to remain below 60. That is an indication for giving
Chest compression.
chest compression. So how do you give chest compression?
बट उससे पहले इंक्यूबेट करना पड़ेगा आपको. अभी इंक्यूबेशन कोड है तो जस्ट पुटिंग इंक्यूबेट हो चुका है.
So what is the position?
laryngeal mask की बात करने लगे
नहीं मैम.
Good. I'm that. We'll come to that in a few days. जब नहीं देखना है.
So this is the
ये तो हम लोग सीख नहीं पाएंगे.
this is the
Pediatrician भी नहीं कर पाएगा.
you can carry on with bag and mask ventilation also, ma'am. This is the intermammary line, and just below this line on the sternum, you have to encircle both your hands and just keep your thumbs. ठीक है? और यहाँ पे what the rhythm now is 1 and 2 and 3 and breathe in. So 1 is compression and is release. 2 is compression and is release. 3 is compression and is release, and then the person on the head end will give 1 breath and release. So 1 and 2 and 3 and
Breathe in.
1 and 2 and 3 and
Breathe in.
1 and 2 and 3 and
Breathe in.
this has to continue for 60 seconds, and there are 120 events, 90 compressions, 90 compressions and 30 ventilation, and after that you are going to again see what is the heart rate. So after that it is a part of advanced NRP which we will not be covering over here.
Not needed also.
Yes.
Not needed.
So my session is over. This is the resource material. I have tried to use the very basic resource material, which is NSSK booklet, Advanced NRP Manual 2024 by IAP NRP NNF 3rd edition, and Dr. Bisht is a co-author for that, and American Academy of Pediatrics textbook of neonatal resuscitation 8th edition.
9th आ गया.
9th आ गया है अभी, but I have used 8th one. So these are the two books, and I would request all of you to please log in on this site. This is by Indian Academy of Pediatrics, NRP Neonatal Resuscitation Program, and first FGM is first golden minute. So it is free, but I can tell you it is priceless, and you should all attend the online course, which is in form of video presentation followed by 4 or 5 MCQs in each session, and you can generate online certificate. Thank you very much.